So hello everyone, my name is Rafael Duarte. I'm a hematologist, head of Department of Hematology at Hospital Puerta de Hierro in Madrid, and I'm past secretary of the EBMT. I'm happy to participate in this masterclass in transplantation organized by IACH. And my topic today is on early post-transplant complications with a particular focus on TMA, on transplant-associated thrombotic microangiopathy. Those are my disclosures, and for the purpose of this talk, there's nothing relevant. Perhaps my work as advisor for Omeros Pharmaceuticals. The reality is that early post-transplant complications include such a diverse range of diseases. They go from bacterial infections, fungal infections, viral infections, even parasitic infections a little later on, to conditioning-related toxicities, hemorrhagic cystitis, organ complications, and all of them, there is a good number of complications that are related to endothelial damage, to endothelial dysfunction. You have those there highlighted in red. Transplant-related microangiopathy is one of them, but engraftment syndrome, acute graft-versus-host disease as well, VOD, diffuse alveolar hemorrhage, idiopathic pneumonia syndrome, all those are related to endothelial dysfunction. And today, we're going to try and focus primarily on transplant-associated thrombotic microangiopathy. It is a rather diverse set of complications that associate with clumping of platelets in the microvasculature associated with microangiopathy and red cell hemolysis and platelet disruption, as well as with lack of oxygenation of the target organs and organ damage. International consensus came about a few years ago to try at least and standardized terminology. And now we can differentiate within TMA patients that have a thrombotic TTP, an HUS, and other conditions associated with thrombotic microangiopathy, including many different complications, and among them, transplant-associated forms of TMA. The pathogenesis includes, as in all those syndromes that we were talking before, includes endothelial injury that comes from a number of factors, and there's factors that are risk factors at the beginning, and there's also triggering factors later on that induce that endothelial injury. And as opposed to some of the other endothelial dysfunction syndromes, something very characteristic of TMA is that it also includes complement activation. Complement activation, as you can see, through the classical pathway, and also complement activation through the alternate pathway. That leads to a profile of complications of TMA, and then leading as well to organ damage and organ dysfunction. The current consensus is that the hypothesis for this complication to happen has two steps, two hits. There's a first hit over a normal endothelium that includes risk factors that can make this more procoagulant, more pro-inflammatory, and that includes prolonged immobilization, bacterial and fungal infections, endothelial injury coming from chemotherapy, radiotherapy, CVCs, residual leukemic cells, growth factor activation, thromboembolism, unrelated donor transplants, many factors, many types of drugs, busulfan, many type of transplant-related risk factors are risk factors for endothelium injury and procoagulation. And over this initial hit, a second hit initiating agents comes from the likes of calcineurin and mTOR inhibitors, tacrolimus, cyclosporin, rapamycin, acute graft-versus-host disease, infection, total body irradiation. So this is important in the sense that management of this complication, one of the first steps that would be reducing these factors and reducing calcineurin inhibitors, for instance, or treating effectively acute infections and acute GVHD that might be leading to this complication. clinical presentation comes in two blocks of symptoms from two different manifestations. Manifestations of microangiopathic hemolytic anemia, and we have in these new onset anemia or higher transfusion requirements, new onset thrombocytopenia or higher transfusion requirements for platelets as well, elevated LDH, schistocytes in the blood, decreased haptoglobin. Schistocytes in particular are hard to compare between centers. We've recently, and Ivan Moiseev from our group at the EBMT published an international study to try and assess how accurately we measure schistocytes. And even though intra-center, there's reasonable homogeneity, from center to center, the numbers vary a lot. So that's a real challenge when you're trying to use schistocytes, not only as a manifestation, but also as a potential diagnostic feature. But also, not only the microangiopathy, we also have the manifestations of organ damage in the kidney, decreased renal function, proteinuria, and this is an early manifestation, and then hypertension that may require more than 2 drugs for management. In the lungs, hypoxemia and respiratory distress, GI tract, abdominal pain, GI bleedings, ileus, and that is a very important topic as well, because many times in acute patients in whom TMA could coincide with GVHD and gut GVHD, the appearance of all these symptoms might be difficult to differentiate from both complications. Central nervous system, polycerositis, all those are manifestations of organ damage in TMA. If we try to look at these from a sequential perspective, it is important to know that there's some of these markers of TMA that appear earlier in the presentation of the disease, and some of them that appear later. This work from Sonata Jodel suggests that hypertension, heart control, proteinuria, LDH are early events and might help us predict, might help us be aware that TMA is happening in these patients. There are many diagnostic criteria and algorithms for these patients that you have in this table summarized. The Clinical Trials Network ones in the US. This is the international working group led by Tapani Ruutu from Finland that would also work with for many years, and many of us use. Chow's criteria are very interesting and recent, and the important thing that they add is the differentiation between a probable TMA in which there's not organ damage established yet, and a real onset TMA with organ damage. And then Sonata Jodel's criteria, which include and benefit from their high expertise and availability of complement studies, and are primarily devised and generated in pediatric setting in children, which is what Sonata patients are. I think it's very important in this context not only look at the criteria, and you're all aware of this among the audience for this master class, but it's also important to see how the manifestations of TMA overlap with those of other endothelial damage syndromes. We've got here symptoms of TMA, and all of this can occur in this context, including organ damage, renal, neurological, multi-organ dysfunction, gut, bleeding, all those that we've also seen, and how those compare to many of the other complications that in an active setting many times are very difficult to differentiate in the context of a patient. I'll just present in the next slide a potential case to illustrate this. We have 36 is one of our patients, 36-year-old woman who received a cord blood transplantation for AML. TBI, fludarabine, cyclophosphamide, and ATG, cyclosporine, and prednisone, and this is our protocol from developing in our hospital that brings together a single unit of cord blood and CD34 highly selected progenitor cells from a third party, most commonly a haploidentical donor. This lady suddenly on day 3 presented with headache, dizziness, blurred vision. CT scan of the head was normal. Increased weight 7%. Liver Doppler ultrasound was normal. We normally monitor Doppler ultrasound and RF elastography prior to transplantation, and then whenever symptoms occur, to try and associate with the possibility of a veno-occlusive disease happening in this patient. So that was normal. And then in the blood test, schistocytes, anemia, low platelets, and acute renal failure of new onset and high LDH. So there's all these symptoms that don't fully define any of the diseases, but that nevertheless they give us hints and ideas to how to manage this patient. This patient received plasma exchange and defibrotide, and we tend to be quite favorable to using defibrotide in this early case, in which even if you don't have the whole diagnostic set, you have a sense of severity that also makes you make clinical decisions. And however, the patient deteriorated very rapidly, respiratory failure, multi-organ failure, and in less than 48 hours passed away in ICU. And one may wonder, what is the real diagnosis? What is what caused this? These patients are complex. This lady had a fungal infection, a systemic fungal infection with a Cellosporium prolificans that was identified only after the patient died in post-mortem analysis that we never were able to diagnose prior to death. So this takes us back to the original description of the complexity of these diagnostics, differential diagnosis in these early complications. Of course, poor prognosis does not only come associated with other forms, and this Cellosporium prolificans was obviously one of the most difficult complications that you can have to face and manage. Also, it associates with patients with TA-TMA. This is a very interesting study from Basel, from Sarah Kraft in Brussels, published last year, that showed not only an association between TMA and GVHD, and also that when they both happen together, the impact on mortality and non-relapse mortality and survival increases, but also shows that those patients that develop TMA, even in the absent, independently in a multivariate setting from those that suffer GVHD, have significantly poorer outcomes. The hazard ratio in the study by Sarah Kraft was over 3-fold for mortality in patients with TA-TMA. So what are the possible prognostic factors in this patient? How can we tell apart who's going to do well and who's going to have such poor outcome? And there's many factors. Proteinuria greater than 30 milligrams per deciliter, elevated serum C5b9 levels, and these have the limitation that most of us have access to these, but not with a very quick turnaround. And therefore, in order to manage patients and be able to make decisions, these results always get to us too late. Age, unrelated or haploidentical donors, TMA index greater than 20, schistocytes counts, TMA without sirolimus exposure, and that's also an interesting point, and then elevated serum creatinine as a sign of organ dysfunction. Perhaps from a practical perspective in clinical management, one of the things that I think is useful to be aware is that there's two clinical presentations. There's those TMAs that present normally without high-risk factors associated with the use of calcineurin inhibitors, cyclosporine, tacrolimus, and those that appear independently from it, not associated with CNI. The former normally respond well and respond better to the discontinuation of the calcineurin inhibitor and replacement with other immunosuppressive drugs. However, those that are not associated with calcineurin inhibitors normally are associated with other complications, acute GVHD, severe infections, and those are in general higher risk forms of TA-TMA and have a poorer outcome. I think that we have to get to the point where we are able to predict this in a more efficient way. Olaf Penach from Berlin and Thomas Luft from Heidelberg have been generating exciting information with E6, these endothelial damage and stress index score that comes with very simple parameters. You just need to have your LDH and your creatinine. Is not a difficult measurement to make in our patients, and they've associated this with non-relapse mortality, with many endothelial dysfunction syndromes, including acute GVHD, but also most recently associated as well with the occurrence of TMA and with factors associated with endothelial damage. This also is having additional validation. We ourselves would be presenting at EBMT, at the virtual EBMT in August, September, our own information validating this in our own patients. And there's and I mentioned here one of the colleagues as well, Eleni Gavrilaki from Greece, who's also looked specifically at E6 at the association with complement activation with C5b9 in allogeneic transplant recipients as a sign of the potential use of E6 to predict risk in these patients. So I'll summarize the diagnostic criteria and management with this graph from Sonata Jodel, in which we bring together several interesting things that I think are useful for the management. First, screen for TMA. What is it that we do in our patients that might be a high risk? And the only way we can do is just look at some of the features. We need to know what we saw before, that there's some of these features that occur earlier and some of these occur later. So full blood counts, LDH, urine analysis for albuminuria and blood pressure, all those are going to be able to give us a warning about the possibility of a suspicion of TMA occurring in our patient. Suspected TMA also comes with that LDH is high, proteinuria and hypertension requiring more than 2 medications. And then we have to do the full lot of diagnosis. It's going to include as well looking at schistocytes, thrombocytopenia, anemia, hypertension, proteinuria, and LDH as well above normal. So how do we make decisions from here? And this is also, I remind you that this algorithm from Sonata comes in the setting primarily of pediatric patients, which overall the evolution is perhaps better than the patients that we see as adult hem-onc physicians and transplanters. The proposal is that if proteinuria is greater than 30 and the soluble C5b9 is also above normal, there's in general, if those are both absent, those two features, you just continue with the clinical monitoring. And then the thing that I would add to this is that we have to perhaps also, in those cases, intervene in terms of withdrawing the risk factors that hit to calcineurin inhibitors, if we can, and also treating acute GVHD or infections that might be triggering this complication. But when we get to the point that these start being either one present, and we have to make decisions on this based on the risk and based on what is that we can change otherwise, or both present, then we need to move on to treatment with more specific drugs. Here in her algorithm is eculizumab that is particularly mentioned. We'll discuss a little bit more about that, what drugs we have available to manage these patients. So from here we go to management. And I'd like to go first on how to prevent and manage TA-TMA. Systematic screening, and these are the recommendations that come from Enrique Carreras and Monse Diaz-Ricard in the chapter on the EBMT handbook, the most recent edition from last year. And so this is a broad recommendation for managing these patients. First, LDH 3 times a week, proteinuria 3 times per week, and blood pressure daily. And proteinuria perhaps is the thing that many of the centers don't normally do as a screening in regular basis in patients. If any of this data suggests any risk, any warning for TA-TMA, schistocytes monitoring quantitative proteinuria, and the measurement of haptoglobin and serum C5b9. And there's good levels for the latter from Zinaida Jodel's data. In children, the reality is that for most of us, getting that information is hard in a timely manner in the management of these patients. And then if patients do get criteria for TA-TMA, then the management is in keeping with what we saw in the algorithm before. If that happens without significant proteinuria and without an increased soluble serum C5b9, then the actions would be stop calcineurin inhibitors, treat any possible triggering cause infection, GVHD, and we'll stay there. However, if there's severe proteinuria, increase C5b9 in serum, then we still have to do all those measurements, and also we need to do specific treatments. What specific treatments can we use in these patients? Of course, therapeutic plasma exchange beyond the supportive management. Therapeutic plasma exchange is one of the options. There's been evidence in some recent prospective studies of complete response rates in the over half to 2/3 of the patients. In particular, the association between therapeutic plasma exchange and rituximab right after TPE associate with good results in these patients. There are many treatment options and based on the pathophysiology of the disease. So it's not only plasma exchange. We've mentioned eculizumab, and we know that's a direct inhibitor of the MAC complement complex. We've got rituximab, many other immunosuppressive drugs that we also use in graft versus host disease and in other indications, and all those are to try and promote to try and block the promotion of endothelial damage, because TPE also acts not only clearing antibodies, but also clearing many other factors that contribute to endothelial damage. And then for those factors that are protectors of the endothelium, there's additional drugs that can be used. We'll just focus on a few of them. Rituximab first, and there's reasonable responses said associated with TPE, with therapeutic plasma exchange, and it should be administered immediately after. The fibrotide, and there's a few reports. This report that mentioned here from IACH is a study from the Pediatric Disease Working Party and the Inborn Errors Working Party of the EBMT, where they reported in total 17 adults and 22 pediatric patients treated with the fibrotide with rates of response, as you can see, in the level of 3/4. We also looked in our center to these same data highlighted here in our own hands, and this data published also a couple of years ago by Maria Martinez Muñoz from my center, looking at 17 consecutive episodes of TA-TMA in our center, treated with the fibrotide. You can see the difference between the resolved episodes and the unresolved episodes in terms of characteristics. Perhaps the most relevant finding is that 2/3 of these patients, 12 out of 17, responded to the fibrotide, and then that the response is overall in monotherapy for a group of patients, but it's also true that in some of these patients there were other treatments. Some of the patients also had TPE as part of the treatment, because it's in a situation so acute. So these patients had other treatments as well. Important as well when we manage this series that do not really have a randomized design, our historical controls. I'd like to highlight that some of the patients that we treated had, according to Cho's definitions, probable TMA. So they had all the features of TMA, but without organ dysfunction. So that might also call from perhaps earlier forms of the disease. So clearly good results. Clearly 2/3 of its patients respond, some of them having received additional drugs in addition to the fibrotide. And the only thing to consider is that still a clear niche, in particular for the patients with organ dysfunction, to manage and to benefit and to improve outcomes of TMA. Rituximab and the fibrotide we've discussed. Eculizumab, without a doubt, is indicated in TA-TMA with proteinuria, and the indication in reality is for atypical SHUS, and this is the closest, the nearest we have right now of an indication for a drug in this setting. It is also primarily developed and used in pediatric patients, and in whom it's been reported the importance of measuring levels of the serum C5b9 in order to be able to adjust treatment and dosage accordingly. And nevertheless is perhaps at this point the approved drug of choice in these patients with the indication of atypical HUS that it currently has. Those are results from Sonata Judel's studies, and you can clearly see, albeit with the limitations of this being historical control, retrospective comparisons, but clearly survival in transplant recipients with high-risk TMA treated with eculizumab clearly is better than what they'd seen before in these same patients. And there's many new potential agents, and I'll just like to mention that in addition to a full blockage of eculizumab, with eculizumab of C5, and therefore the final MAC complex in complement activation, the potential inhibition specific of the lectin pathway with OMS 721, current name narsoplimab, has the potential benefits of sparing the effect of the activation of the blockage of the clinical pathway, which in transplant patients in whom there's a high risk of infection, the overall contribution of the complement and the classical pathway to the resolution of infections might be a limitation from the overall use of eculizumab rather than a more selective inhibitor of the MAC, of the complement activation through the lectin pathway. There's experience out there. We've treated in our center 3 patients already, and the results are very positive with this narsoplimab drug, and it's in phase of development. So I'd like to summarize the presentation. I think that clearly early post-transplant complications are an exciting field. It's a small compendium of so many different things in internal medicine, hemato-oncology, infectious diseases, renal function, and needs a close look with a multidisciplinary team. I think that is one of the areas in hemato-oncology and transplantation that is more exciting. Within those, in the past decade or so, first with the arrival of the fibrotide, and then with the better understanding of the pathophysiology, we've learned that there's a handful of complications that are very directly related at the onset, at the development, with endothelial dysfunction. And of all those, today we've tried to focus on TMA. TMA is not as frequent as graft-versus-host disease or other complications, but it's a potentially very severe complication of the early post-transplant. It is also a complication that comes in different forms. There's risk factors, there's first hits, second hits. I think that from a clinical perspective is useful always to do the differentiation between those that are very clearly CNI associated, calcineurin inhibitor associated, and those tend to go better once you remove the calcineurin inhibitor and you replace it with another immunosuppressive drug. However, those that do not happen in the context of calcineurin inhibitors associated with other risk factors, normally infections, graft-versus-host, and those have a poorer outcome. We have factors, and we know factors to be able to predict outcome, and hopefully E6 and similar scores might be able to help us at the pre-transplant setting to anticipate the occurrence of TMA, and the management, in addition to the support management and to the withdrawal of calcineurin inhibitor and treatments of infections, GVHD, that might be associated with the complication, includes new drugs. Eculizumab is as of today, perhaps the one with an approval in a typical HUS that is closest to the treatment specifically for this complication. There's other complement inhibitors, as mentioned, narsoplimab, that might be coming into the field to help managing these patients in a more specific way. And there's also other drugs, rituximab, TPE, that can also help us manage these patients. So I hope that this summary has been useful. It is a very exciting complication, a very exciting area of work that I hope that all the audience, all of you guys that are participating in this master class find exciting to jump in, because it's something that is giving us an opportunity to improve our patients' outcome, and also to look into new drugs and into new mechanisms of action and diagnostic criteria that may help us manage better our patients. Thank you very much.
Good morning, my friend. So next 25 minutes or so, we are going to briefly review management of long-term complication after transplantation. I have no disclosure, no conflict of interest declare. So educational objectives summarize here. We're going to define what is meant by long-term complication after allotransplant. We will review link between long-term complication and chronic GVHD, very important in terms of screening and preventive aspect. We will describe the chronic GVHD-related long-term complication experienced by transplant survivors. And then we are going to review briefly management part, screening, prevention, and treatment of long-term complication in transplant survivors. At the end, we will review our research priorities. Let me start with two classical case history to start our discussion. Case number one. This case is very well known to us. Briefly, this is a 47-year-old male with AML-CR2 underwent site TBI match unrelated donor transplant in August 2011. At that time, we used to use TBI. As you know, we don't use TBI much nowadays. Post-transplant course was complicated by severe regimen-related toxicity, prolonged oral cavity GVHD mucositis, grade 4 mucositis for a long time, required prolonged TPN administration. And then he developed acute GVHD, maximum grade 2 upper GI, chronic GVHD, multiple organ involvement, persistent oral cavity signs symptoms, burning pain, can't eat well, very sensitive mouth. He remained on cyclosporine, low-dose prednisone, and topical dexamethasone, Swiss and sweet, thinking this was all related to oral cavity graft versus host disease. So no improvement. He remained stable, not losing weight, but symptomatic. I continued to try taper immunosuppression, thinking this is not an chronic GVHD, and requested ENT to get biopsy done locally by local physician. Now, local physician was also semi-transplant physician. He was trained in a transplant program, but practicing general hematology, oncology for more than 10 years. Now, he thought this is a GVHD, so he increased the immunosuppression when he sees the patient, and I tried to decrease immunosuppression, thinking this is not GVHD and need biopsy for further evaluation. Finally, after some time, we were able to convince to get the oral cavity lesion biopsy in February 2015, and it was suggestive of carcinoma in situ, HPV related. Patient underwent wide excision. Histology was also suggestive of invasive disease, and then patient underwent radical surgery. Patient is doing well. We continue to follow him annually in long-term clinic. Nowadays, we follow him via telehealth video visit. Another long-term survivor. Again, case very well known to us, 49-year-old female, obese patient with recurrent Hodgkin's lymphoma. She underwent reduced intensity match-related donor transplant in 2005. Post-transplant course was complicated by acute GVHD, maximum grade 3, multiple organ chronic GVHD, sclerotic skin GVHD, bronchiolitis obliterans on home oxygen in 2006. And she also had a metabolic syndrome, hypertension, hyperlipidemia, and worsening diabetes mellitus. She had a bony complication, osteonecrosis, osteoporosis, vertebral fracture with minimal trauma, I would say spontaneous vertebral fracture, osteonecrosis of both hip joint and required both replacement, decreased libido, hypothyroidism. She had a scleral lens for severe ocular changes, skin cancer, squamous cell multiple site, and HPV-related cervical dysplasia. She was a tracer of multiple organ-specific long-term complication, but she was successfully managed in our long-term transplant clinic. Slide summarizes her psychosocial issues, decreased libido, depression, sleep disturbances, chronic pain, divorce in 2010, no job for some time, lack of interest, chronic fatigue, and physical inactivity. The good news is she's back to work. She's now full-time administrative assistant, works 40 hours a week, able to work on computer with scleral lenses, with hip replacement. She's off a wheelchair now. She's no more on oxygen. Now, let me tell you, we don't see much cases like we reviewed here, but cumulative numbers will continue to rise because, as we all know, number of long-term survivors are rapidly rising. I don't think I need to details on these slides. At the same time, transplant is getting safer and safer over a period of time because we have a better supportive care. We do have an effective antimicrobial agent, particularly antifungal and antiviral. And more importantly, refined management of transplant-related complication. Bottom line message, we're going to see more and more cumulative numbers of long-term survivors, right? And this is the evidence. Slide reviews the CIBMTR outcome data from high volume transplant program. Here we are center number 154 with red arrow with 1 year survival 82% last year. Progressively improved over the years from around 55% 1 year survivals 10 years ago. Now let's discuss something good and new development first. Why transplantation is safer than ever before? Of course, we are smarter than before, especially our next generation transplant force, transplant clinician, no doubt. Other than smartness, main two reasons reviewed here. Number one is management of chronic GVHD, moving progress. We got first FDA approved drug for chronic GVHD, and I expect second drug soon. We had lots of good discussion in last TCT meeting. And we also reviewed those novel drug potentially get approval soon, hopefully, in our IACH webinar last month when we summarized the TCT summary. All information is available on IACH website, free open access webinars. Now, second main reason is concept of immunomodulation opposed to immunosuppression. And third most important is management of chronic GVHD related late complication. Now, we do have aggressive policy to manage late effect after transplantation and access to transplant survivorship clinic, where we can see all dedicated late complication management. Sometimes we call it long-term transplant clinic, long-term follow-up unit, late effect clinic, or GVHD clinic. This is most important. But there are still some ongoing issues. Approximately 15% patient will die, majority from non-disease related issues between year 2 and 10-year post-transplantation. This is one of the highly cited CIBMTR study, still true as of today. Study population includes all patients surviving at least 2 years post-transplant, and 10-year survivor probability of AML, most common indication for transplantation, was 84%. And remember, these are all young patients receiving myeloablative transplant, and median age of cohort in this study was only 28 years, very young patients. And this is another landmark long-term study. Study population includes patients surviving at least 5 years post-transplant. Again, young cohort of nearly 8,000 patients, about 20% young patient died between year 5 and year 20 post-transplantation. As expected, mostly from non-relapse causes, as disease recurrence after 5 years is very rare. Shorter life expectancy among long-term survivors. So what goes wrong in next 30 years? Metabolic complication, pulmonary complication, bone loss, avascular necrosis, delayed immune reconstitution, and related late infection, renal complications, second malignancies, premature aging, physical symptoms, cognitive issues, loss of job, financial problem, disabilities, separation, divorce, suicidal thoughts, so many issues, right? Chronic GVHD and associated immunodeficiency are the primary cause of transplant-related mortality late after allotransplant and contribute directly or indirectly to most list complication. So here we can prioritize how our clinical management and research priorities can be located. Let's review how they die. Most important clue, where we want to invest more money with limited resources, and no one has infinite resources, right? So causes of death is number one, then we can prioritize where to target most. Most common cause in long-term survivor, late death in patients surviving beyond 5 years is second or solid tumor, secondary solid tumor or second malignancy. And nowadays we all give different names, subsequent pneumoplasm, subsequent malignancy. Second most common cause of death in long-term survivor is still infection, which I think preventable. And we will discuss more soon. Other important causes are cardiovascular complication, metabolic complication, pulmonary complication. So let's start with second solid cancer after transplantation, which is the most common cause of late death after transplantation. Transplant recipients have a substantial risk of developing second solid cancer, particularly beyond 5 years after transplant and without reaching a plateau over time. Latency period of developing secondary solid cancer about 3 to 5 years. Incidence increases with time, like 1 to 2% at 5 years to 2 to 5% at 10 years, 5 to 15% at 15 years, and about 25% at 30 years post-transplant. Risk factors are nicely summarized here, but I want to stress here on HPV-related risk, preventable risk. As we all know, HPV is necessary, but not sufficient to cause cancer in HPV-specific malignancy. Other additional factors includes requires persistent HPV disease infection. Other cofactors plays into the roles are immunosuppression, other like HIV, immunosuppressive agents, smoking, and genetic predisposition. As you all know, among most common malignancy after transplants are head and neck cancer, oropharyngeal, GYN cancer, and certain skin cancer. Now, if you look at those common cancers seen in our population post-transplant, they are closely linked to HPV in general population and solid organ transplant recipient. But data are lacking in allotransplant recipients, linking most common second malignancy after SL transplant and HPV. But we do have some data. This is one of our long-term study at IACH. Study protocol requires gynecological examination, including assessment of vulvovaginal GVHD as a part of long-term visit. at least every 6 to 12 months, and more frequently if patient has any clinical finding or symptom. Median follow-up study was 10 years. Genital HPV disease rate were more than double in the setting of extensive GVHD, extensive chronic GVHD, or any patient with genital GVHD. Likely reflecting HPV reactivation rather than new infection. Most of these patients were not sexually active. So reactivation rather than new infection, it implicates immune dysregulation. History of prior HIV, prior HPV, or occurrence of either extensive chronic GVHD or genital GVHD identify the patient who deserve more frequent monitoring. Latency of HPV reactivation may be several years, supporting a window of opportunity for augmenting immunity through HPV vaccination. This is what we don't want to see. Premalignant lesion will drive to cancer. You can see difficult to see picture, cancer of cervix, vulva, vagina, penis, oropharynx, anus over 10 to 30 years, but short time to develop in our patient population. What do we do to prevent or early detection of second malignancy? Best answer is safe transplant procedure so we don't get much chronic GVHD. Hopefully in next few years, on the way, I think PTCY combo may way to go. Meanwhile, preventive measures whenever possible and screening, secondary screening for cancer. Several organizations, as you know, NCCN, American Cancer Society, United States Preventive Task Force, and several similar equivalent organizations in Europe have developed and standardized cancer screening methods that are currently implemented as a part of routine general health evaluation for certain malignancy in general population. I'm talking about general population. But the application of these guidelines to transplant recipients have not been reviewed. Therefore, at CBA, EBMT, and CIBMT are late effect working parties, we develop a consensus approach to establish recommendation for individual secondary cancer in our population. Adults and pediatric transplant recipients were considered in the development of this guidelines. I'm not going to go into details on cancer secretary recommendation because it's available online. Recently published article available on BMT website, open access, second solid cancer screening following hematopoietic cell transplantation, one of the top class article. If you look at the CDC website, I would like to ask you to look at the CDC webpage and enter HPV in a search field. First sentence on top you will see is nearly all sexually active people will get HPV at some time in their life if they do not get the HPV vaccine. Although most HPV infections go away on their own without causing problem, HPV can cause genital warts or cancer, and getting vaccinated against HPV can help prevent this health problem on top of the CDC webpage. So what can we do to help our patient? Simple, and number one answer is some preventive strategy based on what we know, right? HPV vaccination. We offer HPV vaccination starting at 12 months post-transplantation to all our patients, regardless of their prior sexual history and exposure to carcinogenic strain, regardless of their immunosuppression status, disease status. In October 2018, FDA approved Gardasil 9 for men and women aged 27 to 45, all general population. I'm not talking about transplant, general population up to the age of 45. Based on a study that followed women aged 27 through 45 for 3.5 years, they found that original vaccine, which studied Gardasil, was 88% effective in preventing genital warts, vulvar and vaginal precancerous lesion, cervical precancerous lesion, HPV-related survival cancer. So more sense to give all patients HPV vaccination in our population. This figure is from recent NIH study led by our friend Pam Stratton. Slide shows excellent immune response following quadrivalent HPV vaccine in women after allo transplantation. This is a non-randomized clinical trial. As we discussed before, second most common cause of death in long-term survivor is infection. There are three main options to prevent late infection. Number one, vaccination, prophylaxis with antimicrobial agent, which has a lots of negative side, and immunoglobulin substitution without any randomized data. So what is our best weapon? Is vaccination, aggressive post-trans vaccination, very important. In our experience, we are able to reduce the late infections, hospitalization due to infection, and death after aggressive post-transplantation immunization schedule. We do voluntary audit every 6 months to make sure our compliance rate is more than 95%, which is increased from about 45% in 2012. Now, let me tell you one thing. We do get lots of questions about live vaccination in our long-term clinic. Short answer is yes, live vaccine is indicated in eligible patient. MMR, often given, often not given after transplant. It is important to consider in all eligible patients. If you have a doubt, please consider checking titer. If negative, strongly encourage to consider MMR vaccine in eligible patient. MMR often not given, as I said, and this is a nice article summarizing when, how to give MMR vaccine in high-risk population. Now, varicella zoster virus can cause shingles due to VZV reactivation, and reported rate is about 20 to 50% in transplant population, which far exceeds the general population rate. High titer HC vaccine is not recommended post-transplant given the possibility of severe disease and availability of alternative antiviral medication. And now we have a Shingrix. Two dose of Shingrix, 2 to 6 months apart, very effective. We check the titer 2 to 3 months after second dose. If titer is positive, which is the case in most patients, then we discontinue prophylactic acyclovir, valacyclovir, if patient is off immunosuppression. Our admission rate related to shingles have been almost nothing since we started using Shingrix about 2 years ago, and our compliance rate to Shingrix vaccine is almost 100%. These are the relevant recent publications summarized here for your references. Let's switch the gear to cardiovascular complication after transplantation. It's again not uncommon and contribute to late morbidity and mortality at young age. And it accelerates the rate of complication in older individuals and in patients with pre-existing risk of cardiac complication. Effective prevention requires addressing cardiac risk factor and aggressive management. I'm not a cardiologist, but I would say this is one of the best article, recently published article, summarizes the screening and preventive practice recommendation from CIBMTR and EBMT late effect working party open access article. Ocular complication, both GVHD related and non-GVHD related complication, and it greatly affects the quality of life. GVHD, early cataract, premature cataract, and all dryness, lots of issue. Again, we do have an excellent recent publication. There are our recent relevant paper, non-GVHD ocular complication after transplant, ocular GVHD after transplant. Both are expert review recommendation from CIBMTR and EBMT late effect working party with a wonderful tables in it. Please use it as needed and great resources for your patient. Other common long-term complication: increased risk of metabolic syndrome, diabetes mellitus. It is linked to chronic GVHD, TBI, steroid. HbA1c is not a reliable marker. Oral hypoglycemic often not enough. Aggressive management is needed. Male hypogonadism, supplemental testosterone very selectively used in patients with low morning testosterone, and reduced libido or bone mass, important indication. Monitor for LFT, PSA, and hematocrit. Thyroid, TSH elevations are initially subclinical, but most patients do require long-term supplementation. Thyroid adenoma carcinoma may occur at higher rate than expected, especially in those who receive radiation. Adrenal insufficiency, overt or ACTH challenge, high prevalence in one study, 19 of 20 in one study at 1 year post-transplant. Many of these patients require hydrocortisone replacement for a long time. Pituitary growth failure, central hypogonadism, hypothyroidism, TBI, young age at BMT, very important risk factor. And fertility issue, nice relevant papers are summarized here. Clinical Guide to Palliative Preservation, Neurocognitive Guidelines, very important articles there. Now, let me slide again summarizes the cause of death in long-term survivors. Let's switch the gear. We talk about late complication and late death, death beyond 2 year, death beyond 5 year post-transplant, but very limited literature on those surviving, how they live. What is their quality of life? Psychosocial issues beyond 5 years, psychosocial issues beyond 10 year post-transplant. They are cured, but what about the other issues? GVHD, biggest cause of poor quality of life in long-term survivors. This is one of our great study. Patient-reported quality of life is associated with severity of chronic GVHD as measured by NIH criteria. Report on baseline data from chronic GVHD consortium led by Stephanie Lee. Chronic GVHD linked with long-term complication and also poor quality of life. Now we're switching gear to quality of life and psychosocial issues in long-term survival. Late complication have a major impact on recovery and quality of life post-transplant. You can see here cumulative incidence of chronic health condition, worse physical functioning, more severe limitation of useful activity, lower likelihood of return to work after on study. So what are the consequences of these issues? Premature aging, chronic fatigue, poor functioning, both physical and mental functioning, depression, loss of job. All these bring the financial issue, especially young person who loves independent lifestyle. 25% decrease in household income by more than 50%. 30% of out-of-pocket expense more than $8,000. What are going to go for the financial help? People try to find the way to support themselves and family. Best answer is how to support? Apply for disability unemployment benefit. You can see here is very high disability among long-term survivor in this Swiss study. 38% versus 3.5% in general public. Same in USA. I do sign lots of temporary disability. I'm not allowed to sign permanent disability, but I do sign lots of temporary disability. We renewed every 6 months in our long-term transplant clinic. And rarely patient approach an expected route. Excess risk of suicides among survivors, absolute excess risk of 11, and nearly 14 per 100,000 in male long-term survivor. Very sad. And this group of patients suffer from delayed psychological recovery, especially those who had a pre-existing previous psychological, they are at high risk of continued worsening problem. And this is very disturbing. Common reason for frequent ER or clinic visit increases the cost of post-transplant care. 10 plus survivors are high risk of reporting somatic distress compared to their sibling. Somatic symptoms, somatic disorder, formerly known as somatization disorder or somatoform disorder, is a form of mental illness that's causing one or more bodily symptoms, including pain. Symptom can involve one or more different organs or body systems, such as pain, neurological problem, and abdominal complaint. Very common and frequent reason to visit the clinic. How do we help them? Slide summarize the intervention in our program. We refer all our patients first 100 days and later as needed to Vanderbilt Diani Center for Health and Wellness rehab program for partially supervised on unsupervised program. And this is very helpful. Can I say that generally they continue, they become addicted. When they go back home, generally they continue to have this exercise program. What else we can do? Let me tell you. There are lots of approaches people have tried and reported in the literature: acupuncture, massage therapy, meditation, movement therapy, relaxation therapy, spinal meditation, yoga, billion-dollar in this industry. My preferred approach highlighted in red is periodic visits with neuropsychologists for cognitive and behavioral therapy. Works best. In addition, what we can do? Prayer for those who are believers. This is our NIH study led by one of our social worker. Health-related quality of life score, physical, functional, emotional, and social family well-being were well correlated with level of spiritual well-being. This is my summary slide. What next? Research priority, very important. Future efforts should be directed toward assessing the cost effectiveness of survivorship care. We don't have infinite support or financial sources. So what we need to develop newer models, and which we have already transitioned: telehealth service, video visit, decrease the cost of travel, decrease accommodation, hotel cost. Then increasing use of novel targeted immunological agents like bispecific T-cell engager, checkpoint inhibitor, monoclonal antibodies, and CAR-T. Long-term complications faced by these survivors need to be investigated, and future screening and prevention guidelines need to be harmonized to include this group of survivors. Our main issue is lack of prospective study, randomized study. I hope we can do one day on those to fill the randomized study data. And again, to follow long-term or to manage long-term complication is a regulatory requirement based on this fact and Jesse recommendation highlighted in this slide nicely. Now, this is our summary slide. Increasing transplant activity and growing awareness of late complication. Survivors clinic, individual survivors care plans are necessary. We need to have an innovative care model, and we need a excellent support from our non-transplant physician who will be following all our patients locally. And these are some of the resources. ESTCT app, widely used, regularly updated. We have one late effect book, and this is a second edition which meets most of JC and FACT requirement, edited by me and Dr. Professor Tichelli. Hopefully it will be coming out in July 2020. We are waiting for one or two manuscripts to be finalized, and it will be with publisher with excellent guideline, and each chapter has a one summary page for the management guidelines. And I would like to thank you very much for your patience, and I'll be happy to answer if any question. Thank you very much again.